Everybody, can everybody hear me?
Yes, we can hear you.
Fantastic. Well, I just want to extend my personal welcome to everybody, and I appreciate you being here this evening. So the topic for today is fluid and electrolyte balance. And without further ado, let's get right into it. Now, we have a spectrum of people. There are some people who are fully trained surgeons and surgical teachers, and you probably know all this information. But I've always found that this is a difficult topic to teach. So you may find the way I organized it helpful to you when you're trying to teach your students and residents fluid and electrolyte management. And maybe in the discussion, if somebody has a different approach to it, I'd like to hear it, because I can always improve myself. And for those of you who are trainees, I think you will find this particular method of assessing fluid and electrolyte balance and prescribing treatment helpful to you and prevent you from going astray. I just want to point out the ratios of sodium and chloride in seawater as opposed to extracellular fluid. And you can see that there's a preponderance of sodium in seawater and chloride, and the same ratios are present in extracellular fluid, although seawater is more concentrated. So for those of you who believe in evolution, it may be that as we evolved from singular cell organisms floating around the primordial sea, we had to develop mechanisms for maintaining the electrolyte, the milieu that we were these cells were living in. And as evolution developed and we developed into multicellular organisms and multi-organ systems, we still have cells floating around in extracellular fluid. And so we've developed mechanisms for maintaining the fluid and electrolyte balance. Now, for those of you who are creationists, this is maybe an interesting phenomenon, but not something that you accept. But anyway, I always start my the talk off with just comparing this. And here you can see the difference between extracellular and intracellular fluid. Obviously, in extracellular fluid, as you can see, there's a preponderance in sodium and chloride, whereas in intracellular organisms, there's not that much sodium, but there is a tremendous amount of potassium and also phosphates, which are part, of course, of the DNA. Now, if we consider that we are basically a bag of water to a certain extent, and in a 70 kilogram person is approximately 42 liters of total body water, and 2/3 of that is present as intracellular water at 28 liters, and 1/3 or 14 liters is present as extracellular water. All right, having gone through those general things, because you could spend 2 days talking about that, but let's get down to the nitty-gritty about how are you going to manage fluid and electrolytes in your surgical patients. And basically, you have to ask 6 questions. Question number 1, what are the maintenance fluid requirements of my patient? Question number 2, is there a fluid deficit or a fluid excess in my patient? In other words, do I have to make up for fluid losses in addition to providing the maintenance? Question number 3, are there ongoing losses that are going to be continuing? In other words, does the patient have 5 tubes coming out of them with all sorts of fluid draining out of it? Question number 4, does my patient currently have any electrolyte abnormalities that need to be corrected? Question number 5, what is the acid-base status of my patient right now? And do I need to do anything to correct that? And then question number 6 is, what are my patient's caloric requirements? And of course, nutritional support is a separate topic, which we're not going to discuss extensively today, but I always put it on the list because in surgical patients, we got to be thinking about nutritional replacement from the very beginning. Because if it's a complex case and we don't pay attention to nutrition, our patient's going to starve to death. All right. So what about maintenance requirements? Well, as you all know, there are certain obligatory losses. We all lose at a minimum close to a liter a day in an adult of fluid just by evaporation from skin and mucous membranes. Now, those of you who are living and working in equatorial Africa, you know that you're going to lose a lot more. For example, when I'm working in the operating room in Dar es Salaam, I I lose liters and liters of fluid because I'm not used to the heat. In fact, I've suffered I think 3 or 4 kidney stones while I'm in Africa because it's very hard for me to replace all the fluid that I'm losing. So you have to take into account the environment and as well as so the water evaporation may in fact be a lot more than a liter per day, depending on the environment. Now, we like to have 25 to 30 cc's of the urine being made per day in an adult, and so there's going to be an obligatory loss of urine. You don't necessarily lose any sodium because of the renin-aldosterone system. If you are really hypovolemic, you won't lose any salt. So there's not an obligatory loss of salt. However, because of the sodium-potassium pump in the kidney, there is an obligatory loss of somewhere between 30 and 40 milliequivalents of potassium a day in an adult. And many people don't realize this. And when I was first arrived many years ago at a hospital in Africa, almost every patient was hypokalemic. And the reason was that there was not routine potassium replacement in the fluids. And then once we got that corrected, almost none of the patients were hypokalemic after that. So you have to realize that you have to replace potassium losses. We're going to get into that in a minute. So what are our maintenance fluid requirements? Well, you probably all learned this in medical school, but I'll just remind you that for the first 10 kilograms in a baby, it's 4 cc's per kilogram per hour. For the next 10 kilograms after that, it's 2 cc's per kilogram per hour. And then above 20 kilograms, it's about 1 cc per kilogram per hour. So if we have let's make the arithmetic easy, a 50 kilogram person, so so it's going to be 40 cc's per hour for the first 10 kilograms. It's going to be 20 cc's per kilogram per hour for up to 20 kilograms. So now we get a patient who's a 20 kilogram person who's getting 60 cc's per hour, and then it's 30 kilograms after that to 50. So that's 1 cc, that's per kilogram. So that's 30. So 60 and 30 is 90 cc. So for a 50 kilogram person, we're going to be, the maintenance requirement is going to be approximately 90 cc's per hour. And then of course, if we're losing a lot of sweat for one reason or other, we have to make that up. So we now know how to give maintenance requirements. We've answered the first question. 4 cc's per kilogram per hour for the first 10 kilograms, 2 cc's per kilogram per hour for the next 10, and then 1 cc per kilogram per hour after that. And that's an approximate maintenance requirements. So now the next question is, when you're sitting down to write your fluids, the next question you want to ask is, does my patient have a fluid deficit? Now, on the surgery service, most often the patient is going to be arriving with a fluid deficit. So how are we going to assess that? Well, first thing we could do is we could take a history. In other words, if the patient has been found in a pool of blood, or the patient has had a bowel obstruction for 4 days, or the patient has cholera, for example, and has had a lot of diarrhea, we know from the history that there's going to be a fluid deficit. Now, one great way of assessing hypovolemia, which I think we often don't pay attention to, are orthostatic vital signs. In other words, if the patient's lying down and let's say has a blood pressure of 100 and a heart rate of say 90, and it's a fit young person, he may be maintaining his vital signs pretty well. But if we sit him up and he's hypovolemic, his blood pressure may drop and the heart rate may go up, and that's a sign of postural hypotension, a very good indicator of hypovolemia. And for example, if you're in the operating room and you're working with a very good anesthesiologist and nurse anesthetist, almost always you will notice that the person will check the blood pressure and pulse of the patient in the supine position and crank the table up and recheck it to see whether the patient has postural hypotension or not, orthostatic vital signs, and if so, give some fluid before induction of anesthesia, because the patient may have been NPO after midnight, the case may be starting late, and the patient may be dry. So that if you induce anesthesia in a hypovolemic patient, the bottom may drop out of the blood pressure, then you got all sorts of excitement. Whereas if you replace fluids prior to induction of anesthesia, you can prevent that from happening. The next thing you can look at is peripheral perfusion. One of my professors used to say that the big toe is the best cardiac output machine that you have, because if you got a big toe that's warm, pink, and well perfused, and if you press on the skin of the foot and you get immediate reperfusion, that tells you got pretty good volume status, pretty good cardiac output. Same thing for urine output. I always say that the kidney is the best cardiac output machine, because as long as the patient is making urine, you're in good shape. The problem is when you first see the patient, say in the emergency room, you really may not know what the urine output is. You might be able to get it from the history, asking the patient when the last time they passed urine was and how much. Another thing, if the patient's in the hospital and you happen to be able to weigh the patient, a big drop in weight on a short period of time is almost always due to fluid loss. The problem is in adults, it's not easy to weigh the patients, but if you're working with children and babies, it's pretty easy to weigh them every day and check for weight changes, which can be a sign of fluid loss. We always talk about skin turgor, whether you can pick the skin up, or dry mucous membranes. But you know, if you wait till the patient has skin turgor or very dry mucous membrane, those are very late signs of hypovolemia. If you have a patient being transferred into you after getting inadequate fluid resuscitation for a long period of time, you may notice dry mucous membranes and skin turgor, but hopefully if you are seeing the patient from the beginning, that will never happen. Sometimes in babies, you can feel full fontanelles, and sometimes in babies, the liver will move up and down depending on the fluid status of the baby, but that's not usually the case in adults. Another way of assessing fluid loss is the hemorrhage classification, which was developed by the Committee on Trauma of the American College of Surgeons. So they divided hemorrhage up into 4 classes. Class 1 hemorrhage is a volume loss up to 15%, or up to 750 cc's of blood. And in this case, if that's all you've lost, you don't necessarily have a change in blood pressure, pulse, or respiratory rate. So for example, if you go in to donate a unit of blood. You walk in there, and they put the needle in the vein. You give, say, somewhere between 300 and 500 cc's of blood taken out of you. They give you a glass of orange juice. You lie down for a minute. You get up. They check your blood pressure, make sure you don't have postural hypertension. And then after 20 or 30 minutes, you're on your way. So that's class 1 hemorrhage. Class 2 hemorrhage involves loss of blood up to 30% of the blood volume. In other words, between 750 and 1,500 cc's of blood. Remember, the blood volume, a good way of estimating blood volume is 80 cc's per kilogram in an adult. That's the approximate blood volume of the average adult, 80 cc's per kilogram. So in this case, if you've lost, say, a liter to a liter and a half of blood, you're likely to be tachycardic. The pulse pressure, that is the difference between the systolic and the diastolic blood pressure, is going to be reduced. And these patients are generally anxious, they're unhappy. And you may notice that the urine output has diminished to less than 30 cc's per hour. Now, class 3 hemorrhage, which is up to 40% of the blood volume loss, in other words, up to 2 liters. Now we got a real problem. Now we got a patient who has a decreased mental status, confused, he's tachypnic, he's tachycardic, he's hypotensive, and he has a profoundly reduced urine output. This guy's in big trouble. And class 4 hemorrhage, now we got a guy with 1 foot in the grave and another on a banana peel. This guy's about to die. He's lost more than 40% of his blood volume, more than 2 liters. He's unresponsive. He's got cold, pale skin, profound hypotension, tachycardia, and he's not making any urine at all. And I'm sure all of you who are experienced have seen patients with class 4 hemorrhage. Now, I'm going to stop for a minute and ask if there are any questions up to this point, anything that I've said that it's unclear. Anybody want to make any comments? Mugisha, you want to, do we have any comments, or should I just keep going?
Maybe you keep going because I've received none in the chat box.
Okay, very good. All right, so the first question is maintenance requirements. The second is fluid deficit. Now, fluid deficit, I've given you ways of assessing it, but we haven't really assessed exactly how much. So you basically have to wet your finger and put it up in the air and see which way the wind is blowing, if you know what I mean. It's not an exact thing, but basically, if you've got a fluid deficit, you want to estimate as best you can how much of the fluid deficit that exists, and then depending on what the vital signs are, if the patient's normotensive and has a normal heart rate, you can replace that fluid deficit slowly over the next 4 to 6 hours. On the other hand, if the guy's got a blood pressure of 40 and a heart rate of 130, you need to replace that fluid immediately. So those are the first 2 questions. The third question is, are there any ongoing losses? And that's relatively easy to assess in a post-operative patient, because you've got an NG tube, you may have a drain or two, and you can actually measure the amount of fluid losses every 4 hours. Now, here's the thing. When I finished my internship, I went to the Massachusetts General Hospital, where I did 2 years of training in anesthesia before they started training in surgery. When I got to the Massachusetts General Hospital, which is one of the greatest hospitals in the world, I got there and I went into the ICU and I saw 3 patients with a hydrochloric acid drip. And I said, my God, these patients are so sick. I've never seen a patient with a hydrochloric acid drip. And I said, man, these are the sickest patients in the world. But after I was there for about a week or 2, I realized that the reason I had never had to use a hydrochloric acid drip is I had never got so far behind on my nasogastric fluid replacement that my patients had lost so much hydrogen ion from the hydrochloric acid from the NG tube output, which wasn't being replaced, my patients never got screwed up enough that they needed a hydrochloric acid drip. And that the guys there at that time, I'm sure it's not happening now, were just way behind on their fluid replacement. So here's how you avoid getting into trouble. You're having a lot of fluid output. All you have to do is replace cc per cc every 4 hours what's coming out of the tubes. So for example, let's say it's an NG tube problem, and let's say you've got 200 cc's of fluid draining every 4 hours. Just as an example, that's a lot, but let's just say it is. All right. So what you're going to do is you've already written your maintenance requirements and your fluid replacement for a fluid deficit. All right. So let's say you decided that you're going to give your patient 100, and let's make the arithmetic easy. You're going to give your patient 150 cc's an hour, which is a lot of fluid, but let's say you have a fluid deficit that you're correcting, plus maintenance requirements. And in addition to that, this guy has put out in the last 4 hours, 200 cc's of fluid. So what you're going to do is you're going to say, replace NG output Q4H with, so 50 times 4 is 200, 50 cc's per hour of such and such a fluid. Okay, so now you're going to give what? What do we say? 150 plus another 50 is now you're for the next 4 hours, the patient's going to get 200 cc's an hour, and then the nurse will reassess, remeasure how much came out in the past 4 hours, and then let's say it's 100 cc's. So she's going to add, so the next 4 hours, it's going to be, instead of 50 cc's an hour, it's going to be 25 cc's per hour for 4 hours, because 20 times 4 is 100. So you can replace ongoing losses, and it can be either cc per cc or half cc per cc, depending on the fluid balance of your patient. In other words, if you thought your patient, if you want to get rid of a little fluid in your patient, you can replace half cc per cc. If the patient's dry, you should replace cc per cc. Now, the question is, what kind of fluid should you replace? Well, here is as a practical matter for NG replacement, if you replace with 1 liter of D5, that's 5% dextrose and half normal saline, plus 20 milliequivalents of KCl, that will maintain electrolyte homeostasis in most circumstances, assuming normal renal function. Assuming the patient has normal renal function, if you give 1 liter of D5 half normal saline plus 20 milliequivalents of KCl, D5 is 5% dextrose. Now, if you don't have half normal saline, you can make it by injecting concentrated sodium chloride. Say put this 60 or 70 milliequivalents of sodium chloride in a 5% dextrose solution. And then also you have to add potassium. Remember, there's a lot of potassium in nasogastric output. So you have to replace it with both sodium chloride and potassium chloride. Okay. Now, this is a chart of the electrolyte composition of various gastrointestinal secretions. And I'm not going to go, I don't expect you to memorize this or know it. You can easily look it up on the internet or in a textbook. But as I said, for all practical purposes, if you use D5 half normals with 20 milliequivalents of KCl, that will take care of the fluid replacement problems. Now, there's one thing that you should know, however, and that is if you're having a lot of diarrhea, or if you're having a fistula, a small bowel or duodenal fistula, you may be losing a lot of bicarbonate, because in pancreatic secretions, as you can see, there's a lot of bicarbonate. So if you have a duodenal fistula, for example, you're going to be losing a lot of pancreatic fluid. So you may be losing a lot of bicarbonate. So in that situation, you may need to add, instead of giving only sodium chloride, you may have to give some sodium bicarbonate. Add some bicarbonate, sodium bicarbonate to your fluid solution. Now, if you follow your fluid, if you manage your fluids with the 6 questions that we're in the middle of discussing, you're not going to have any trouble with fluid and electrolyte balance. However, you may be receiving patients in transfer who have been all screwed up because of less than optimal fluid management. So in this case, so if you've got a very complex problem and you're having trouble figuring it out, you can, and you're having a high output situation, say from a fistula or something like that, and you're not sure what's going on. What you can do is just take an aliquot of this fistula output and send it to the lab for electrolyte analysis. And they can tell you exactly what the electrolyte concentration is in there. So when you're doing your replacement of ongoing losses, you can make up your own solution. You can make up Mugisha solution, for example, and put the exact electrolyte concentration that you measured in there. Now, I've only had to do this maybe twice in my entire career. So it's an unusual situation, but it is an option. Most of the time, as I said, if you just replace with P5 half plus 20K, you'll be fine. So we have discussed so far maintenance requirements. Remember, 100 cc's per kilo for the first 10 kilos. 4 cc's per kilo per hour for the first 10, 2 cc's per kilo per hour for the next 10, and then 1 cc per kilo per hour afterwards. Assess fluid deficit using history, orthostatic vital signs, urine output, peripheral perfusion, using vital signs to assess the degree of blood loss for the American College of Surgeons classification, etc. In terms of electrolyte and in terms of ongoing loss, you can measure them and replace them either cc per cc or half cc per cc every 4 hours. And if you do that, you're not going to have any electrolyte abnormalities. However, you may be receiving patients who have profound electrolyte abnormalities. So let's look at some of those electrolyte abnormalities and how can we correct them. Well, one of the most common electrolyte abnormalities is abnormalities in sodium. Now, I think we have to distinguish between sodium loss and hyponatremia, because they're 2 different things. Sodium loss means a loss of total body water, because when you're peeing out sodium, you're peeing out water. So when your total body water is low, you have to replace with the sodium chloride. Hyponatremia, which is a very common electrolyte abnormality, just means that there is less solute, that is sodium, than solvent, which is in the plasma. So in other words, you can have a patient who is hypervolemic, in other words, has too much water, and yet they could be hyponatremic. In other words, they just have less salt than water, and vice versa. So hypernatremia just means that there's more sodium, that is solute, than solvent plasma. Okay. Once we understand that, let's go look at things. Now, as a general rule on the surgery service, hypernatremia is more dangerous and difficult to correct than hyponatremia. And the best method of treatment is free water through the GI tract. But many times the GI tract in our patients is not working well. So we can correct this by giving intravenous fluids, but you should not really give dextrose and water as to for a severely hypernatremic. Let's say you have a patient with a serum sodium of 160 to 165, which is basically we don't want to be anywhere near this. But if it happens, we want to correct with dextrose and quarter normal saline. In other words, you should give a small amount of saline, because remember, we have a blood-brain barrier. And if we make the plasma hypotonic vis-a-vis the brain, water will be diffusing through the water channels into the central nervous system, and we can get cerebral edema. We want to just slowly correct the hypernatremia with hypotonic solution with that is dextrose and quarter normal saline, but not free water intravenously. And then we want to correct this very slowly over a period of 12 to 24 hours. So for hypotonic fluid loss, that is hyponatremia, we first want to correct the tonicity. And then we can correct any fluid deficit through just regular IV correction. So how do you decide how much sodium to give? You have a patient who's profoundly hyponatremic. So what does hyponatremia mean? Let's say we have a patient who's got a serum sodium of 115 or below. Okay, a profoundly hyponatremic patient. Well, when you do your correction, you never want to correct to 140, which is the normal serum sodium. You want to correct to 130. So you take 130, and let's say the serum sodium is 110 to make the arithmetic easy. So 130 minus the serum sodium of 110 is 20, times 0.6, which is an assumption of the sodium space, times the weight in kilograms. And that'll give you the approximate milliequivalents of sodium that's in the deficit, that's deficient. And you only want to correct this by half, because you never want to overshoot. So if we say in a 50 kilogram person, and we're going to that has a serum sodium of 120, so 20 times, so there's a 20 milliequivalent deficit between where we are and 130. Multiply that by 50 is 0, 0. That's 0, 0. That is basically 1,000. But we're basically going to give 600 milli and multiply that by 0.6. We're going to be giving 600 milliequivalents of sodium as our estimated deficit. We're going to correct that by half, which is 300. And then, so that's basically 2 liters of normal saline, or we can give it as hypertonic saline slowly. I hope that's clear to everybody. So if you just remember this formula, that's how you correct. That's how you correct hyponatremia. But always remember, don't give the full amount. Correct by half. You can always give more, but if you overshoot, you're going to create another problem, that is hypernatremia. Now, there are a lot of causes of water excess. Most of the time, it's seen on the medical service because you can water intoxication, the syndrome of inappropriate ADH. But I'll give you an example from my own family. My daughter, who was a young woman, liked to go to the gym a lot. work out. And in America, every young woman who goes to the gym has a bottle of mineral water. So she would be working out, losing a lot of fluid, and basically drinking a lot of free water. And one time she called me up from the emergency room where she had been lightheaded, went to the emergency room, and she had a serum sodium of 114. And so she had self-induced water intoxication. And I would be telling jokes to the medical students about this for 20 years, about water intoxication from drinking so much mineral water without electrolytes in it. And then I said to my daughter, I said, I've been telling jokes about this for 20 years, and there you went and done it. So that's just an example of one way of getting water intoxication. Most of the time, we see it on the medical service and not the surgical service. But sometimes we do see the syndrome of inappropriate ADH, where we have a low sodium, but we're having inappropriate secretion of significant amounts of sodium in the face of hyponatremia. And of course, the treatment is generally fluid restriction. And hypertonic fluid loss, which we've discussed, and I mentioned how dangerous this is. The free water deficit, in other words, how much free water do you have to give, can be assessed by this formula. I'm not going to go into it in detail, but the point is, you want to replace free water as quarter normal saline, hypotonic, but normal saline, and you can give it both as a combination of sodium chloride and sodium bicarbonate. These formulas can be looked up easily on the internet. I don't think you have to remember the formula, except to know that it exists, and know that if you've got a hypertonic situation, the best way to calculate the deficit is to go to the formula, and then you know approximately what amounts you're dealing with. But again, the general rule, make your corrections slowly, not rapidly. Now, something that kills patients around the world regularly is hyperkalemia. And we see it in acute renal failure, in crush syndrome, in malignant hyperthermia after anesthesia, sometimes with metabolic acidosis, and sometimes with massive transfusions of old blood where you have lysis of red cells and a lot of potassium floating. Now, the hyperkalemia symptoms are muscle weakness, but there's a characteristic EKG finding, which is peaked T waves. And in fact, when I was an intern 50 years ago, we weren't able to measure electrolytes rapidly like we can now. But when we would be treating cases of diabetic ketoacidosis and giving insulin, the insulin, of course, drives the potassium into the cell. And so that when you're treating an elevated blood sugar, a massively elevated blood sugar with diabetic ketoacidosis and giving insulin, the patient, the patients can drop their potassium very rapidly and get an arrhythmia. And so what I would do is just every hour get an EKG strip, and as soon as the T waves started lowering, that's when I would add potassium to the bottle. Because if I waited 4 to 6 hours till I got my electrolyte results back at that time, it would be too late. So I would assess when to put the potassium in the bottle because of lowering of the T waves. Now, of course, it's irrelevant because you can get an answer back at least in my hospital in 10 minutes. So what's the treatment for hyperkalemia? Well, you probably all know this information, but to review it, it's hypertonic glucose, and you can give basically a unit of insulin per 2 grams of glucose, and generally the glucose comes in big. You can give it in a big syringe, so you can give 10 units of insulin with D25, 2 milligrams per kilogram over 30 minutes, and that will result in a rapid lowering of the glucose. And you can also give rapid lowering of the potassium. So you're going to give glucose and insulin to lower the potassium. You can also correct the acidosis with sodium bicarbonate. We generally give calcium gluconate, 100 milligrams per kilogram, and the calcium gluconate is not going to do anything about the potassium, but it is going to stabilize the membranes in the heart to try to reduce the risk of arrhythmias with these rapid fluxes in potassium. And then for a slower or more chronic treatment, you can give K-Electrolyte either orally through an NG tube or through a retention enema. And that, of course, K-Electrolyte is a resin which binds potassium ions and will keep the potassium down. So hypertonic glucose and insulin, sodium bicarbonate, calcium gluconate to stabilize the cardiac membranes, and K-Electrolyte. Also, we can dialyze the patient, of course, as well. Now, why is this? Here we go. And there's the K-Electrolyte, 1 to 2 grams per kilogram with sorbitol, either orally or you can give 5 milligrams of sorbitol for a gram of K-Electrolyte as a retention enema. Mugisha, is everything that I've said up until now been clear? We're giving a lot of information at a fairly rapid pace. Does anybody want to ask any questions or?
Yes, we have 3 questions so far.
Okay.
Number 1, do we still correct the sodium deficit by half in all patients with ongoing fluid losses, such as when you have a stoma, ureterosigmoidostomy, or you have ileostomy, or high output fistulas? Do we need to do it by half? That's question number 1. May you respond to that? Okay,
so that's a very good question, and it depends on the fluid status of your patients, because remember, as surgeons, and I include myself in this, we are guilty of overloading our patients with fluid. As a general rule, we usually give too much fluid, and so if you have a patient with a fistula, you should assess your patient's fluid status. So if the patient is overloaded with fluid, then you could give half CC per CC replacement. On the other hand, if your patient is in good fluid balance, then I would replace it CC per CC. So the answer is replace CC per CC unless you think the patient's overloaded, and then you want to restrict the fluids a little bit. Any comments on my answer? Is that clear? Okay. What's the second question?
The second question is, when you are doing estimation of the fluid deficit, can it be done in a patient with edema, and all parameters will not be applicable to a generalized edema, patient with generalized edema without checking IVC volume?
That's a great question. So an edematous patient, by definition, has elevated total body water. On the other hand, an edematous patient can have intravascular hypotension, even though they're edematous. So if you have a patient who's edematous, but has signs of hypotension, that is hypotension or hypovolemia, that is hypotension, tachycardia, postural changes, etc., then the best thing to do is to do a more accurate assessment of intravascular volume, and that can be done by placing a central venous pressure catheter in to measure the central venous pressure, or it could be done by using echocardiography to assess the size of the vena cava, the size of the right atrium and right ventricle. So in other words, if you don't have the filling of the right side of the heart, then the patient has low intravascular volume, even though the total body water of the patient may be elevated. And a good example of this is, let's say you have a cirrhotic patient with ascites and but who's hypotensive. So now you have to think about how you're going to replace this patient's fluid, because if we're going to be pouring salt water into the patient, we know that the salt water is going to leak out into the peritoneal cavity and into the soft tissues, and you're going to make the edema worse, and it may not remain in the intravascular space. So in that kind of situation, if you have available salt pore albumin or fresh frozen plasma or blood, if the patient's hematocrit is low, that would be a better fluid replacement in that particular situation, because the fluid that you're giving is more likely to remain in the intravascular space and less likely in the short run to leak out into the interstitium or end up as ascites. Is my answer to that question clear, or do anybody have a different opinion?
I think it is clear. I have nothing. Yeah, it is clear.
Okay. Are there any other? I think there was a third question.
No, there were two by then.
Okay. So let's go on to the next electrolyte abnormality, which is hypocalcemia. Now, we sometimes see this in surgical patients who've undergone a total thyroidectomy, if due to difficult anatomy or technical error or whatever, all four parathyroid glands have either been removed, or sometimes the parathyroid glands are present, but maybe edematous because of a difficult dissection, and they stop working for a while. So in this case, you can see a low calcium level post-operative. And of course, there are lots of other medical reasons to see hypocalcemia, which are listed in the slide. Sometimes in severe pancreatitis, where we have saponification of the pancreas, where the fatty acids are combined with calcium to precipitate sort of a soapy substance that forms around the pancreas. Probably some of you have seen that at surgery. Sometimes we can get hypocalcemia. So the symptoms, of course, are weakness, paresthesia, particularly around the lips, cramping. You can see a prolonged QT interval on the EKG, and you can see Trousseau sign and Khvostek sign. Remember, Khvostek sign is when you tap over the seventh nerve, the patient can get the spasm of the muscles around the eyes. And Trousseau sign is when you have internal rotation of the hand, and you particularly see this. You can induce it by taking a blood pressure cuff and pumping up the blood pressure cuff. And if you get flexion of the wrist and internal rotation of the hand, that's a Trousseau sign. So, I was always taught to look for paresthesias in patients who've had a total thyroidectomy in the immediate postoperative period to assess whether the patient might be developing hypocalcemia. But you have to be careful how you do that, because if you say to the patients, you have any tingling or numbness around your lips, the patient will sometimes can imagine these things because they're nervous. So I would just ask them, do you have if you have any unusual feelings, and if they're telling you they got some numbness or some tingling around their lips, that's a sign that they may need calcium replacement. A relatively early sign. And how are you going to do it? You're going to give either calcium chloride at 10 milligrams per kilogram or calcium gluconate at 100 milligrams per kilogram IV. Or you can also replace it just with some calcium carbonate pills, which is in America, we have this company called Tums, which people often take for acid indigestion. It's got a lot of calcium in it. So that's hypocalcemia. Hypercalcemia can be very dangerous and actually cause coma, particularly with malignant hypercalcemia. But we more often see it with hyperparathyroidism. It's so common, at least in America, that to measure calcium, that we're picking up a lot of cases of hyperparathyroidism that were missed, in the previous era, because calcium was not routinely measured. So you can get it from vitamin D intoxication, as I mentioned, malignancy, metastatic carcinoma of the breast, the bones is a particularly common cause of it. You can see it with prolonged immobilization. Sometimes you can see it with the prolonged use of diuretics, particularly thiazide diuretics. So a lot of the symptoms, weakness, lethargy, are also similar to hypocalcemia, but on the EKG, instead of a prolonged QT interval, you'll see a short one. You may see abdominal cramping, and in severe cases, the patient could be comatose. So the first aid for hypercalcemia is hydration and diuresis. The sodium chloride in intravenous infusion and some Lasix. You can treat hypercalcemia, of course, with the hemodialysis. You can treat it with steroids. You can treat it with calcitonin, but the use of biphosphonates, pamidronate, has really revolutionized the treatment of hypercalcemia, particularly malignant hypercalcemia, which used to be a very, very difficult problem to manage. Now, pamidronate, biphosphonate, which interferes with the function of osteoclasts in the bone, that can usually take care of the problem. Now, I am not an expert on the management of magnesium abnormalities. Perhaps somebody in the group knows a lot about it. I haven't seen it that often, except to say that when you're having a calcium problem, you should also check magnesium, because magnesium problems are often associated with hypercalcemia problems. And in patients, if you have septic patients and septic shock, when you're managing it, it's a good idea to check the magnesium as well as the calcium levels. And of course, with toxemia of pregnancy, of course, magnesium abnormalities are common, and it has to be treated with magnesium. we're going to finish up here with phosphate problems. You can see it with starvation. You can see it with malabsorption, vitamin D deficiency, and the treatment is a phosphate replacement. And sometimes we see hyperphosphatemia associated with low calcium in renal failure, and as you know from managing chronic renal failure patients, there's basically a routine phosphate is restricted in their diets. We give phosphate binders, a trade name in the United States for a commonly used phosphate binder is Amphigel, and of course with renal failure, the real treatment is dialysis, which can dialyze out the phosphate. All right, so let's review what we've been talking about so far. The first question is maintenance of fluid requirements. The second, is there a fluid deficit? The third question, is there ongoing losses? The fourth question is, does my patient have electrolyte abnormalities? Yes or no? And if so, what do I need to do about it? We just covered that. The fifth question that you should be asking when you're writing fluid electrolyte orders is, what is my patient's acid-base status? Now remember, the primary buffer in the blood for acid is hemoglobin. There are a lot of hydrogen receptors on the hemoglobin molecule, and most often elevated acid is taken care of by hemoglobin. However, if so much acid is being produced that it overwhelms the buffering capacity of hemoglobin, and there are some other proteins in the blood, like albumin, will also have a combined hydrogen ion. But when those mechanisms are overwhelmed, then we have hydrogen ion combining with water to produce carbonic acid, which then dissociates the hydrogen ions and bicarbonate ions. I'm not going to get into hydronium and all that. This, for the purposes of our discussion, carbonic acid associates the hydrogen ion and bicarbonate ions. And we know that the total CO2 that we're bound, so when you're doing an electrolyte and you're measuring the total CO2, what you're measuring is the solubility constant of carbon dioxide in blood, which is 0.03, which is a very, very small number, plus the bicarbonate ion. So for all intents and purposes, when we're measuring total CO2, we're measuring bicarbonate ion. And we know by the Henderson-Hasselbalch equation that the pH in the blood is equal to the pK plus the logarithm of bicarbonate over 0.03 times the pCO2. So that will give you the pH. That's the Henderson-Hasselbalch equation, if you remember it. But to make this simple, basically, the pH is a function of the ratio of bicarbonate to CO2. And now look at this. What organ governs the bicarbonate concentration in the body? And the answer to that is it's the kidney. The kidney controls the bicarbonate ion level in the blood by excreting bicarbonate. And the lungs, of course, control the CO2 in the blood by excreting CO2. So in other words, the acid-base balance is governed in the body by an intimate dance, as it were, a pas de deux, between the kidneys and the lung. The kidneys and the lung work in concert to maintain electrolyte balance. So, one way to assess acid-base balance is measurement of the anion gap. Now we know that the electrolyte, the charge has to be pretty much equal to maintain neutral electrolyte balance and electrical charge. So we know that in the extracellular fluid in the plasma, the sodium ion is the major charge. Potassium, very little potassium in the plasma, as we mentioned at the beginning. So let's just forget the potassium. So the major positive charge in the blood is sodium. The two major negative charges in the blood, of course, are chloride ions and bicarbonate ions. So now we know that there are other charges like potassium and other negative anions there, which are functioning. So there is a normal gap that if you subtract the sodium, which is around 140, plus the sum of the chloride and the bicarbonate ions, measured in milliequivalents per liter, there is a normal anion gap somewhere between 12 and 14 milliequivalents per liter. So if we have metabolic acidosis, in other words, if the patient's total CO2 is low, and we have a normal anion gap, that means that we have an abnormal loss of bicarbonate. And what might this be? Well, if we have a patient with massive diarrhea, say from cholera, or we have a patient with a high output duodenal fistula, where we're losing a lot of bicarbonate from the pancreas, we may have a patient with a metabolic acidosis, that is a low CO2, with a normal anion gap. And the treatment would be replacement of the bicarbonate ion. We can give some ammonium chloride. As I mentioned, you can give dilute hydrochloric acid, which I've never had to do. But generally, if you replace the bicarbonate losses, this will not occur. And if you write your fluids according to the 6 questions, this is never going to happen to a patient under your management, because you're going to be replacing all of this stuff while it happens. So you'll never have a problem. You'll only be correcting somebody else's problem. Now, what happens if you have a metabolic acidosis with an anion gap? That is a difference between the sodium and the sum of the chloride and bicarbonate ions more than 12 to 14 milliequivalents. Say it's 20 or 25 milliequivalents, which is a big anion gap. Well, in this case, you must have an addition of some outside acid, and usually it's due to either diabetic ketoacidosis, where you have beta hydroxybutyric and acetoacetic acid, or more commonly on the surgery service, you're going to have a patient with lactic acidosis because of shock, inadequate perfusion. So I've given you the 6 questions that you have to ask. What's the maintenance requirements? What's the fluid deficit? What's the ongoing losses? What's the electrolyte analysis? And what's the acid-base status? Now, you guys are probably, for the residents, you guys are wondering, well, what's this guy making this big deal out of? If I noted if my appendectomy patient, I hang up a bottle of dextrose in water or dextrose in saline or whatever, and drip it in, the guy's going to be fine. He's going to be eating in a day or two, and then he's going to be going home. Well, that's correct, because as long as the kidney is working, you don't have to have it exactly right. If you just hit the side of the barn, the kidney will correct all our errors. But if you want to learn how to manage electrolytes in sick patients, you should ask yourself these 6 questions on every patient that you're writing fluid orders on. How long does it take to ask the questions? In a normal patient, it takes 30 seconds or 45 seconds. But if you keep asking these questions over and over again, it will become second nature to you. So when you have a patient with a difficult problem, it's no big deal. Whereas if you start trying to figure it out with a difficult patient and you're not used to doing it, then it could be a challenge. But just ask us, what's my maintenance? What's my patient's maintenance fluid requirements, and calculate it. That's going to take you 10 seconds. What's the fluid deficit? That may take you a little bit longer, but not a lot longer. Do I have any ongoing losses? And in your complex cases, the answer is usually yes. And then can I replace it every 4 hours? The answer is yes. But you have to work closely with the nurses, particularly at the beginning if they're not used to doing it. So you explain to them what's happening so they understand. Does my patient have any electrolyte abnormalities? Most of the time, the answer is going to be no. But if they do have but if they do have an electrolyte abnormality, you'll at least identify it. And then if you don't remember these formulas, no problem. You can just go to the internet, and in less than 5 minutes, you'll have the answer. Does my patient have an acid-base base abnormality? Yes or no? If the answer is yes, it's usually going to be in the ICU, and then you know how to deal with it. And then lastly, I'm just going to say a word about caloric requirements. You should ask yourself in surgical patients, what's my patient's caloric requirements? But we're not going to spend a lot of time on that now. Let's see, except to say, I just want to point out one thing, that there are 3.4 kilocalories per gram of glucose. That's the only thing we're going to say in this lecture. So let's look at the conversion of percent to grams. A 1% solution is 10 milligrams per cc or 10 milligrams per liter. I'm sorry, I have a spelling mistake there. Okay, so if we have 5% dextrose in water, that means we have 50 grams of dextrose in a liter of solution. 50 grams of dextrose times 3.4 kilograms per gram of glucose means that in that 1 liter of solution, you have a total of 170 kilocalories of glucose. That's it. So let's say you're giving your patient 3 liters a day of some solution with 5% dextrose in it. You're having, let's make the arithmetic easy. So let's say it's 200 kilocalories instead of 170. So 200 times 3 is 600 kilocalories that the patient is getting intravenously. He's not eating. That means that this sick patient is getting less than half of his maintenance caloric requirements in a 24-hour period. And this guy's sick, so he probably has increased caloric requirements. So if you think that by giving dextrose and water over a 24-hour period, you're providing you're giving your patient nutrition, you're living in a dream, because it's not happening. You're giving less than half of the requirements. And I just wanted to make that point, because this lecture is not about surgical nutrition, but I just wanted to, you always have to, when you're writing fluid orders, always think, is my patient getting nutrition, yes or no? If not, when is he expected to eat? So if you're waiting 2 weeks, 2.5 weeks before you suddenly decide to give nutritional support to your patient, you waited way too long. This guy is starving to death right now. And you're much better off early on considering some type of nutritional support in a patient that's in trouble. And having said all that, I will now conclude the lecture and open it up to Dr. Mugisha to conduct a discussion. Thank you all very much for your attention.
Thank you very much for a very detailed discussion. So far, we have some questions in the chat box, and the first question is about, we have 4 questions in the chat box. Number 1 is there any role of determining the shock index for a previously established the underlying cause of hypovolemic shock? And for establishing hypovolemic natremia, could the osmolarity test be appropriate instead of just merely correcting sodium without considering the level of glucose in the blood? Maybe we start with those one, then we'll come with another questions. If you are interested to chip in the discussion, you can unmute and make a comment or write in the chat box.
Yeah, now some of you may disagree with some of the things that I've said, and if so, feel free to weigh in. So as I understood, the first question is, is that grading system for the American College of Surgeons that I presented. I didn't quite get it. Is it useful when? Mugisha?
Pardon?
I didn't totally understand the first question.
Yeah, the gentleman is asking about shock index, and I think
I don't know what shock
Is it-
index means. Does that mean that with the thing that I presented, or is the shock index something else?
maybe he can unmute and clarify more. Meanwhile, you can be answering the second question as we wait for his clarification about correcting hyponatremia without looking to the osmolarity levels.
Without looking at the
And,
glucose levels?
Yes,
Well, I think they,
measure osmolarity.
oh, with osmolality. I understand the question. Yeah, I think that checking, if you have the ability to check osmolality, that's a fine thing to do. But if you've got a very low glucose, you know pretty much that you got a hypoosmolar patient. So I think that you can use osmolality, particularly if you're assessing whether you got any syndrome of inappropriate ADH. But if the serum sodium is profoundly low, and I'm not talking about a serum sodium of 120. That's not a particularly dangerous level. It needs to be corrected, but it's not going to cause a seizure or anything like that. But if you've got a serum sodium below 115, 110, something like that, that's a very dangerous level of serum sodium, and that needs to be corrected pretty quickly with hypernatremic saline, just to get you up to a reasonable level where you're not going to have a seizure or something like that. Did I answer that question? Or maybe the person who asked it wants to make a comment. Maybe that person uses osmolality, and if so, maybe he can tell us how he does it.
Thank you very much. Another question is about, is there any really a role in bicarb replacement in a patient with an ongoing metabolic acidosis? A such patient who is septic?
Okay, that's the
bicarb will be used up very quickly.
That's a fantastic question, and you can overdo bicarb replacement and get yourself into a lot of trouble. So if you got a patient in shock has got a metabolic acidosis, the correct treatment is restoration of intravascular, restoration of perfusion. And if you're hypovolemic, give volume. If it's a heart problem, give we talked about this during the ICU course, support cardiac output by a variety of methods. In other words, not necessarily treatment of the metabolic acidosis itself, because once you improve perfusion, you deliver oxygen and glucose to the mitochondria. You now will then reverse the anaerobic metabolism to metabolic to aerobic metabolism. You won't be producing lactic acid, and then the metabolic acidosis will resolve. So if the patient's in shock, I wouldn't necessarily give bicarb. I would treat the shock. If the patient has a chronic metabolic acidosis due to, say, losses from bicarbonate, due to a duodenal fistula or something like that, then I think it's appropriate to replace bicarbonate. And of course, that patient may at the same time be hypovolemic. So you may have to be replacing bicarb and giving it. Now, there is a big debate about whether giving bicarbonate during cardiopulmonary resuscitation is appropriate or not. And there's some literature saying that it's not appropriate, but but all I can say is that that in my own personal experience, I've had patients who have been in in the process of resuscitation, I'm talking about cardiac massage, either external or internal, for a half hour, 40 minutes, and weren't responding. And then when I turned around and I said, did this guy get any bicarb? And they said, no. And I said, well, can you do me a personal favor and give some sodium bicarbonate, even though Joe Schmo in Chicago wrote a paper saying you shouldn't give it. And then we had some cardiac rhythm return, and we had an alive patient, and a resuscitated patient who went home. So there is a disagreement in the literature, and of course what I'm talking about is anecdotal experience, which is not science. But I'm just saying, I would say the use of bicarbonate in resuscitation is controversial. I agree that it's very easy to overshoot sodium bicarbonate, particularly in the stress of resuscitation. I agree with that, but I think that in selected cases that it's appropriate. But for shock in an alive patient, in other words, the guy whose heart is functioning, the treatment, treat the shock, stop the bleeding, restore intravascular volume, and the metabolic acid acidosis will go away. Did I appropriately answer that question?
I think so. The next question is about, in your opinion, since there are conflicting views, does ringer lactate solution really affect the potassium content in the patient with hyperkalemia? In some areas that may be only fluid available.
Okay, I'm sorry, Mugisha, I didn't totally understand the question. In my opinion, what?
Do you think giving ringer lactate solution really affect the potassium content in a patient with the hyperkalemia, or is it relative or absolute contraindicated?
Okay, all right, so that's there's a big controversy in the literature about the use of Ringer's lactate in resuscitation with trauma. And the reason it was developed was to develop a balanced salt solution. Now, the Ringer's lactate itself can result in a lactic acidosis, can result, there's some potassium in it. So I think a balanced salt solution without a lot of lactate is a preferable solution. But if you're just giving a couple of liters of 1 or 2 liters of Ringer's lactate, I don't think it matters what you use. You can use sodium chloride, you can use a balanced salt solution if you're giving a small amount of fluid. On the other hand, if you got a patient who's profoundly in shock, you got big time blood loss, and you're going to be giving liters and liters of fluid, it does make a difference. So it would be better to choose a solution different than Ringer's lactate in that type of situation. Of course, what that patient really needs is blood, fresh frozen plasma, etc. Did I answer that question appropriately? Or does the person who asked it want to make a comment or ask a follow-up question?
Good morning, Dr. Schaefer.
Hi.
Hi, I'm the one that asked the question. My name is Dr. Said.
Okay.
I wanted to do a follow-up on that question and put in a comment. Usually the ongoing losses of 0.6 milligram per day, 0.4 to 0.6 milligrams per day of potassium. However much you raise it, we can only raise it by 20 to 40 microequivalent per day, or if we have a central line, we can go up to 60, 80. This is to stop phlebitis. Now, if we're going to if we have in some areas, there's only Ringer's lactate that is widely available, because normal saline is the most widely used, especially in Tanzania. So with the Ringer's lactate, the amount is excessively small to be able to think it is about 20 or 10 microequivalent. And this is milliequivalent, and this is per half liter. So in order to make a really profound change, you would need about 10 liters or more, whereby you in that case, in that case, you wouldn't have to, you'd have to put in you'd have to put in blood products as well that also have potassium in that. So in saying that I shouldn't give, in saying that I shouldn't give Ringer's lactate because there have been studies that have been done, and these studies have showed that it doesn't really raise it, but it is constricting. The June.
Let me respond to that question because I think that's a great question.
Okay.
If your patient is so profoundly hypokalemic that they need, so they're behind, let's say 100 milliequivalents of potassium. Let's say that.
Okay.
That means that you have received the patient for somebody else, or
Yes.
or you have made you haven't provided potassium replacement for several days. Do you agree with that statement?
Yes, I do.
Okay, so in that situation, and you've got a sick patient, I agree with you that concentrated, even 40 milliequivalents in 1 liter is going to cause phlebitis. So because potassium is an irritant, as you correctly pointed out. So in that case, you want to replace potassium, but you don't want to overload your patient with fluid, right? Because it's a separate issue. So that patient needs to have a potassium drip placed through a central line. And let me just say, if you've got a patient on a potassium drip, that potassium drip should be on an infusion pump, not with a regular drip, because giving a potassium drip is very dangerous if you give too much. And I have seen several patients die as a result of a rapid infusion of hypertonic potassium in an attempt to correct potassium. So I've saying that. So the patient needs to be in an ICU, monitored under on an infusion pump. So giving that on the war, if the patient's potassium is 2.1 or something, and you think you need to get that up rapidly because of the patient's condition, the guy needs to be in the ICU on an infusion pump. That's number one. Number two, hopefully, if you're managing the patient from the beginning, you're not going to be in a situation like that, because you know that the minimum potassium that you're going to have to give in an adult 30 to 40 milliequivalents a day in your regular fluid management. So the fact that this guy has gotten so low means that he's either been managed on another service or another hospital and gotten all screwed up, or somebody who was managing the fluids on your service didn't do it right. That's why I like this method of asking the 6 questions, because if you ask the 6 questions, you won't get a patient in this situation. So regarding Ringer's lactate, that's just a commercial solution. If you think you need more potassium, there's no reason not to squirt some potassium chloride in the, say you want to give another 20 milliequivalents of potassium chloride, just take 20 milligrams of potassium chloride, squirt it into the IV bottle, and then you're ready to go. Understand what I'm saying?
Yes, I do. Yes, you did.
Do you agree with what I just said, or do you disagree?
I still have a constricting opinion because we have been taught, or it's been drilled into our brains, and a lot of my fellow doctors in the forum can attest to it, that if a patient has even minimal hyperkalemia, Ringer's lactate is completely contraindicated. It's like a taboo.
Why?
Even if that's what is been told. That's what we have been told. I challenge, because it will result in lactic acidosis. It will further aggravate the hyperkalemia that is already there, when in the event it is really just a minimal amount that really won't, it's like a drop in the ocean. It really won't cause anything in a patient who's actually stable, hemodynamically stable, in a patient whose kidneys are functioning, in a patient who's just probably dehydrated. And that's the only solution that you have. We have been told that Ringer's lactate is a no-no. It's not supposed to be used completely. And there have been studies that show.
I think I've got your point, and in the interest of time, we know the math. We've got your point, and the explanation that have been made by Prof. Are really valid. However, there are two different schools of thoughts when it comes to use of electrolyte, use of ringer lactate. There are people who believe in the all medicine, like the way you are presenting, and there are people who are thinking scientifically, like the way Prof has. It is patient-based selection. You will see and make a judicial judgment. This judicial judgment out of the current patient situation. You know, to this patient, you might give a ringer lactate. He may react differently from another patient. And you may sometimes blame, you may sometimes say, oh, I take this wrongly, and my patient has complicated to this and this. But I think what we need to use to have the science behind and approach the patient individually and see what best can you
let me just say, we're about to end our thing, but we have a very senior surgeon here on the line, Dr. Makia. Dr. Makia,
Hi.
you have an opinion about Dr. Saeed's comment?
Unfortunately, I've just joined. Just coming from Loganzilla now.
Okay, so you didn't hear that?
Yeah, I missed it. I wish I could join earlier.
Okay, well, no problem. I just thought that you might have heard. So I would say to end this, Dr. Saeed, I think that there's a very easy answer to your question. If the only fluid you have is Ringer's lactate and there's no other fluid available, you have to give Ringer's lactate. And I would say that if you're not giving excessive volumes of Ringer's lactate, it's not going to make it. My own opinion is it's not going to make a big difference in the short run.
Understood. Thank you.
Yeah. All right, Dr. Mugisha, back to you.
Yeah, thank you very much. I think we have really have a wonderful discussion. I'm very sorry for some of our colleagues who, for different reasons, have joined late, but we have covered a number of issues, and time is not on our side unless we accept one hand, the last hand from Bahati, and then we'll be winding up.
Yes, sir. Okay, I've just a small contribution on the last discussion. Actually, the literature is very clear. There are no differences between the crystals when it comes to resuscitation. So the literature has gone around all the standard fluids, and they have found no significant difference between the 3 or 4 of them. So Ringer lactate, Normosa, and whatever, there are no significant difference between them. So whatever you have, you can liberally use. Thank you.
Well, thank you very much for your comment.
Yeah, so thank you very much for the wonderful discussion that we had. We have noted, all of us, that it is important to take note of
Hello.
Hello.
I think is hello.
Yes, we can hear you.
Yeah, we didn't hear the last comment. I think something went wrong.
Yeah, he said, this was Dr. Robert. He said,
Yes.
the literature is very clear if for the fluid of resuscitations that
Yes.
should be used. Yeah, and someone, if it's the only fluid that is available, please use it as you resuscitate the patient.
Yeah, I think, well, you have no option, and you have to keep the vein open, and you have to resuscitate that particular patient to get back the volume normal. So I think that is it, while you are struggling to have the appropriate fluid.
Yeah.
Yeah. Yeah.
You are right. Yeah.
Yeah.
Yes, we are coming to an end, unless Dr. Bill, you have some closing remarks that you can tell us. But
No
it was a wonderful discussion.
No closing remarks, except to just repeat this, the 6 questions. What's the maintenance requirements? What is the fluid deficit? What are the ongoing losses? What are the electrolyte abnormalities? What's the acid-base status? And what are the nutritional requirements of my patients? If you use those 6 questions every time you write fluid orders, you will unlikely to get into fluid and electrolyte problems. And that concludes my remarks.
Yeah. Thank you very much. Myself, I'll also conclude this talk by saying if you don't know how to manage patients' fluid imbalance and electrolyte imbalance, you're not yet a surgeon. So this is to show how important these few slides that we have discussed today can make a difference in a patient. I'm looking forward to all of us utilizing the refresher knowledge that we have, or reminder knowledge that we have got from Professor Bill for the benefit of our patients. We encourage discussions around different groups of surgeons and see how best you can improve your learning and your memories on how to give fluid therapy and a correct electrolyte imbalance. We want to thank Dr. Bill again for this evening here in Africa, in Tanzania, for spending more than 90 minutes discussing about fluid. Next week, we'll be talking about nutrition in surgery, and we'll be talking about how to take care of patient nutrition in perioperative period. It is the same time, 6 to 6:30. Please make a timetable available. I'll share the link as soon as I get it. Otherwise, thank you very much. Na poleni wale mliochelewa. Asante.
Okay,
Bye-bye.
Asante.
Miss you, Bill.
Hi, great to see you, Dr. Bakia.
Bye. Thank you.
Bye-bye. Bye-bye.
Bye.